I'm going to start a lecture on psychiatry. This is one of the difficult portions in most of the exams, but if you have a good understanding, you're easily gonna get through this. So starting with the postpartum mental health issues. So there are the three things: postpartum blues, depression, and psychosis. So starting with the postpartum blues, this is just be having a low mood. Okay, you're anxious, tearful, and just a low mood. And it's typically 3 to 7 days following a childbirth. This time frame is important. Okay, you need to remember this thing. When you are confused in certain things, okay, and these three things, they are not meant to be confused, by the way, but you can get some idea from the time as well. So postpartum blue, it is just having low moods after the delivery. That's 3 to 7 days, and you need not to do anything, just to reassure the patient. Then comes the postpartum depression. This is being depressive, like having low mood, you lose interest in the daily activities, disturbed sleep, and occasionally there are the suicidal thoughts and thoughts of harming the baby occasionally. Okay, so they peak in 3 to 4 weeks, and what you need to do, the first thing is CBT, cognitive behavioral therapy, and you can give this SSRIs as well. SSRIs, these are the first line for the depression. Then comes the postpartum psychosis. So here, as the name implies, the psychosis, okay, they have the symptoms of the psychosis. So they have the thoughts of harming the baby, they hear voices and the hallucination, and that is psychosis, like hallucinations and delusions. And they have thought of harming themselves as well as the baby. Sometimes, like these mothers, they are thinking that the baby is evil, or even the world is evil in which the baby is, like world is evil. Okay, so they begin 2 to 4 days, but they peak at 2 weeks. Okay, and these patients need the admission. Okay, and you give them antipsychotics because it's psychotic psychosis. Okay, and the mood stabilizers, and sometimes you do the ECT. ECT is only the option you need to choose when they have the suicidal thoughts. Okay, some suicidal thoughts, okay, frequent suicidal thoughts. Somebody wants to commit a suicide. Okay, like in the severe depression. Okay, they have the frequent thoughts. Then you go for like ECT. So psychosis, it's very easy. They will be having the hallucinations and the delusions, thought of harming the baby and themselves. So this is easy to recognize. Postpartum blues is just a low mood. Postpartum depression, it's a depression, like depressive symptoms they are having. Okay. So moving to the next thing. Okay, so let's go to the somatic symptoms and related disorders. So the first one is somatic system disorder, or you call it somatization. Okay, so these people, okay, they are having the symptoms which are having no organic cause, and they are having these symptoms for like greater than 2 years, 2 or greater than 2 years, and they have gone through so many testing and that's negative. Okay, but still they believe that they are having some problem. Okay, so that is also called somatization, that somebody is coming to you again and again and saying that he is having a problem, and he has gone like he's having a pain abdomen, coming again and again, doing the CT, each and everything that is negative, but still he is convinced that he is having some problem over here. And ideally that should be like for the 2 years or more than 2 years. Okay, that is somatization or somatic symptoms disorder. Okay, so you're gonna remember this one from, as it is somatic, so from as they are having the symptoms for greater than 2 years, okay, and they have gone through so many testing, okay, and the labs which are negative. Next come the hypochondriac or illness anxiety disorder. Okay, so here is the C. Okay, so they From the C, you're going to remember a word which I'm going to tell you, that is cancer. Okay, so they believe that they are having some serious problem like HIV, like cancer, okay, despite reassurance. Okay, in somatization, somatic system disorder, okay, the things which the patient is actually thinking of that he is having, they are like they are less serious as compared to, okay, hypochondriac disorder or illness anxiety disorder, where there is like cancer or the HIV. Okay, so you're gonna remember it like it's a C over there to remember cancer. The patient saying that he is having a cancer. Okay, now the patient's coming to you, maybe he's telling a story. Okay, my father was having a cancer. I'm thinking that's the same thing, or maybe he's not relating this thing, but he's saying that I believe I'm having a cancer. He is going to say you something serious over here. So what's the treatment? Go for the CBT. Okay, but he will be having some simple thing. Okay, and he will be correlating this thing with something serious. Okay, like he's having a headache, he's saying I'm having a cancer. Okay, I'm having a hemorrhage or something like that. Okay, then comes the Munchausen syndrome. So it is actually a falsification and fabrication of patient's symptoms. Okay, like somebody is coming to you, I'm giving you an example to make it understand. Okay, in an easy way. That somebody is coming to you, okay, and he's having the vomitus, okay, he's vomiting, and he's saying that, okay, I'm having a blood stain vomiting, okay, that what we call hematemesis. Okay, but maybe he's having a vomiting, but that is not, the blood is not there, and he's just trying to fabricate that one. And what will happen that in the hospital, if he's having, say for example, he's saying that I'm having a bloody diarrhea, okay, he will be just having the diarrhea, but he's saying there's bloody diarrhea. Okay, so in the hospital, he will be unable to produce those symptoms, okay, because he is falsifying those things. Okay, he's trying to fabricate the things to get the medical attention. Okay, if you ask him, okay, bring the stool sample, you're saying that you're having a bloody diarrhea, so he will be unable to produce that one. So the next thing is conversion disorder. Okay, conversion disorder. So this is loss of motor or sensory function. Okay, how this patient is coming to you, okay, and maybe he has seen some accident over there, and now he cannot move his limb. Okay, there's no sensation, okay, in his any of the limbs. So for example, okay, so there could be paralysis, okay, maybe blindness without any cause. Okay, so patient is coming to you and he's saying that, okay, I cannot move the hand, I cannot feel anything over here. So there's apparent, there will be the loss of sensation. Okay, he cannot move a limb, particularly if he has seen something, okay, like an accident, or if he has gone through any of the things, like a death of one of. So the next one is anorexia nervosa. So this is particularly prevalent in young girls. Okay, they have significant weight loss due to the food restriction. Actually, these patients, they are thinking, despite being underweight, they think and they look themselves as overweight. That's why they stop eating. And sometimes there's a self-induced vomiting as well. So they have actually the fear of getting obese. So they have a BMI of less than 18.5. You know that the BMI, the normal BMI is 18.5 to 24.9. Okay, that's the normal BMI. Let's discuss a little bit about the PMI as well. So from 24.9, if you add the 5, okay, that's gonna be like 29.9. 18.5 to 24.9, that's normal. Anything that is below 18.5, that is underweight, and anything that is above 24.9 to 29.9, that is overweight. And then you add 5, that's going to be type 1 obese, and then again 5, that's type 2, and anything that is above 40, that is morbidly obese. So they are underweight, but they are thinking themselves, okay, they perceive themselves as they are overweight. So they have hypoglycemia, bradycardia, hypokalemia. Everything is low in anorexia nervosa, except you need to remember 2 C's and 2 G's. C is glucose, G is glucose, and the growth hormone, they are high, and cortisol and cholesterol, they are high in these patients. Rest of the things, they are low. Management, that totally depends on the BMI as well as the complications. So if the BMI is 15, even if there is no complication, you need to admit the patient. If that's not in the option, like eating disorder unit, you need to go for that. And from 15 to 17.5, without any complications, if the medical complications are there, there's no second option, you need to admit the patient or urgently refer to the eating disorder unit. From 15 to 17.5, without any complications, eating disorder unit, you need to refer to the local community health services. This is the next thing, that is the bulimia nervosa. In contrary to anorexia nervosa, where the patient doesn't eat, here the patient eats too much, but that is followed by self-induced vomiting or excess use of laxatives and diuretics. And the clincher over here is that they have the thickened calluses on the hand because of the self-induced vomiting, because these fingers, they do rub against their teeth. So they have, the other thing is that they have the BMI that is greater than 17.5. The treatment over here is cognitive behavioral therapy, and if it doesn't work, or if he has given that they have tried the cognitive behavioral therapy but it's not working, the next option will be high dose fluoxetine, that is an SSRI, high dose fluoxetine. So now comes the autism spectrum disorder. So autism, that is important as well. So an autistic child, what are the symptoms in an autistic child? So when you call them, they don't respond. They don't make any eye contact. They make the repetitive movements. Maybe they are playing with the toy and they're playing with their toy again and again. If they're doing something, they're doing it again and again. And they speak excessively. These are autistic. Once they start, it is difficult to stop them. So this is autism, autistic spectrum disorder. So you go for like behavioral development programs and speech and language therapy. So the other one is Asperger syndrome. That's a high functioning autism, because their IQ level is average or above average. Again, they have the difficulty in socializing as well. So, and another thing that is with this is attention deficit hyperactivity disorder. These children, they do make careless mistakes. They have short attention spans, and they cannot sit still, and excessively talk. They are unable to concentrate, and they constantly change their activity. In autism, they do the repetitive moments. Here they're unable to concentrate and constantly changing their activity. So yeah, they are hyperactive, hyper impulse, and as I said that they are unable to concentrate, and they are easily get distracted. So in the children, what is the management? That is methylphenidate, that's the first line. And yes, you need to have the sessions, like focused group parent training programs. And CBT is the option as well. Mostly it is in the attention deficit hyperactive disorder is in the children. Well, the cause, if I talk about the cause of this thing, that could be like harsh parenting, poverty, parental depression, low achievements in those children where there are like break-up marriages in the family, like in the parents, or if they have gone through some abuse. So let's do this scenario. Okay, a 6-year-old was brought in the hospital saying that he is easily get distracted and interrupted. Is also clueless and unable to stay at the task. As I already said, they have short attention span and constantly changing their activity. You need to remember this thing. Okay, so that is ADHD, that is attention deficit hyperactive disorder. Okay, so the next thing is now is mania and the hypomania. Okay, so mania is actually the elevated mood, and the hypomania is it's elevated but not up to the extent where the mania is simply. Okay, what is the difference between the mania and the hypomania, by the way? Okay, you need to remember what I'm going to tell you. Mania, it lasts for 7 days mostly, but the hypomania, it's like 3 to 4 days. In the mania, there's a severe functional impairment. Well, that's not the thing in the hypomania. In the mania, there are the psychotic symptoms like hallucinations, okay, or delusions. In the hypomania, there are no psychotic symptoms, and the mania may require hospitalization, like if that is gone out beyond a certain point. But in the hypomania, you need not require a hospitalization. Okay, so this is the difference between the mania and the hypomania. Okay, mania has a longer duration. There's a severe functional impairment. There are the psychotic symptoms like delusions and hallucinations. So they are the elevated mood. Both are the elevated mood. Mania, it's more as compared to the hypomania. So up to 7 days, as I said, there is a functional impairment. There are the grandiose ideas, like I'm a very famous personality. Grandiose delusions are like this. Okay, I'm a very famous guy. I'm a very rich guy. Okay, overactivity. Okay, easily distracted. Yeah, it's written over there, by the way. The one most important thing that is you need to distinguish between the mania and the hypomania is the psychotic symptoms, that is hallucinations and the delusions. Hypomania is a milder version, as I said, okay, and there is no functional impairment, okay, or they don't need hospitalization. So this is what I have already told you. Now comes the flight of idea. Flight of idea is that the patient is having too many ideas, and when he is talking to, he's jumping from one thing to the other. He's telling you the one thing, and at the very next moment or in between, okay, he's talking about the one thing, and now he's jumping to a new thing. Okay, maybe he is talking to you about a particular place. Okay, and now he is talking about a totally opposite thing. Okay, and he keeps on jumping from one thing to the other while talking. That's called the flight of ideas. Now comes the depression. It's very important. So depression is constant low mood, loss of interest or play in most of the activities. Okay, plus 3 of the following: either fatigue, worthlessness, suicidal thoughts, decreased concentration, insomnia, okay, weight loss. Okay, and its symptoms should be there for the 2 weeks. That is important. If you are having these symptoms for greater than 2 weeks, okay, then you're gonna label only these patients having a depression. Okay, like you have low mood, okay, you're feeling worthless, you're having a suicidal thoughts, having the weight loss, or if you are having the insomnia, or even if you are like sleeping too much. And the early sign of, now here comes an MCQ. The early sign of depression, as far as the sleep is concerned, it's early waking up in the morning. Okay, that is the first thing. Okay, and then comes the insomnia, generalized, okay, sleep disturbance. If they ask you about the first thing, okay, what's gonna happen as far as the sleep is concerned, that is early waking up in the morning. Okay, now what is the treatment as far as depression is concerned? CBT. Okay, and then comes the antidepressants. Those are the SSRI, fluoxetine, sertraline, escitalopram. Okay, SSRIs. SSRIs are the first line drugs, okay, in as far as the depression is concerned. Let's discuss a little bit about the SSRIs as well. So you have in the SSRIs fluoxetine, paroxetine, sertraline, citalopram, and the escitalopram. Okay, mostly okay, fluoxetine is given, and citalopram. Okay, these are the good drugs. Now, like, let's discuss a little bit about these SSRIs. So fluoxetine and citalopram, as I said, they are preferred. Okay, SSRIs, they cause the GI disturbance. Okay, and that's why if the patient is coming to you and they are saying that it's not giving you any idea, and here it's saying that they have left the medication. The patient is coming to you and he has left the medication. So most commonly, what could be the reason? That is the GI disturbance. And SSRIs, you need to like take care when you are prescribing the SSRIs. You need not to prescribe an NSAID to the patient because there's a risk of GI bleed. Then there's another important MCQ as far as sertraline is considered. That is safe in the patients who are having the ischemic heart disease. So if you are going to prescribe a patient who is having ischemic heart disease, so always choose sertraline. Okay, sertraline. Citalopram, okay, this causes the long QT. Long QT. Sertraline you need to give in an MI patient. Generally, okay, the safe are like you need to choose the preferred one are fluoxetine and citalopram. Okay, whenever you are giving a warfarin and a heparin, okay, then better avoid the SSRIs. Give mirtazapine. That is a there is a thing like tricyclic antidepressant. It is a tetracycline antidepressant. Mirtazapine. Okay, so if you are giving the warfarin to someone or heparin, then don't give the SSRI. This is because of the interaction. So give mirtazapine. That's a tetracycline antidepressant. General rule is that you need to continue the SSRIs for the 6-month post-remission. Like if the patient was in the depression, you gave it and now he's feeling better. So you need to continue for the 6 months post-remission. This means that once he's better, you need to take them like SSRIs for the 6 months. This is okay to avoid the remission. Okay, and if you are going to stop an SSRI, you need to taper an SSRI for 4 weeks, and then you need to stop. You cannot abruptly stop the SSRIs because they are going to cause the discontinuation symptoms. Okay, restlessness, agitation, sweating. Okay, and the highest discontinuation symptoms are related to this paroxetine. Okay, paroxetine. Highest discontinuation symptoms. Okay, I'm going to summarize it. So fluoxetine and citalopram, they are generally preferred. Sertraline is useful in MI. Paroxetine has highest discontinuation symptoms. Citalopram causes the long QT. Do not give it the SSRIs with the warfarin, the heparin. Instead, give mirtazapine, that is the tetracycline antidepressant. And if the patient is not taking the SSRI, the most possible thing is the GI disturbance. And do not give the SSRI with the NSAIDs because that's going to cause the GI bleed. And you need to give them for at least 6 months post-remission, okay, to prevent the recurrence. And if you are going to withdraw it, okay, you're going to hold that one, you need to taper it over 4 weeks, at least 4 weeks, okay? And these drugs, they do take like 3 to 4 weeks, okay, to take their action. Like their action starts again within like 3 to 4 weeks. So you need to tell the patient every time he's coming to you that this drug is going to work like after 3 to 4 weeks, okay? So you need to take them on the